35% of adults ages 20 years or older have pre-diabetes. That number goes up to 50% in people over 65. Within the next 20 years, more than half of the United States population will be classified as obese. That's insane. And 438 million people worldwide will be diagnosed with diabetes. This is beyond huge. And looking at these daunting figures, you have to wonder, what can we do to stem this epidemic? And in our context here today, how can technology be able to help play a part where traditional methods have left off and failed? Well, I'm going to leave the daunting task of addressing this question to our panel. No pressure. I'm really excited to introduce our moderator for this session, Dr. Anand Iyer, President and COO of WellDoc. Dr. Iyer oversees the deployment of the company's cell phone and web-based diabetes management platform and leads efforts to integrate WellDoc's solution internationally into mainstream chronic disease management programs. He brings more than 20 years of consulting experience, including having served as a director partner at PRTM Management Consultants in the firm's communications industry group and led its wireless solutions practice. I think we're in great hands. It's yours.
Thank you, Jill. Welcome. We have that dubious task of keeping you all awake after whatever you ate for lunch. We'll ask everybody to count their calories. Timing of this presentation couldn't be better. Well, listen, thank you, Jill, for the introduction. What I'd like to do is kind of set the stage for this panel discussion and then introduce our illustrious panel. And what they'll do is they'll kind of go through and provide some brief thoughts and comments, and then we've kind of caucused earlier on and discussed a couple of themes that we thought would be relevant and I think engaging and informative in this whole realm of really this pandemic that is obesity and diabetes. It's interesting, I always say by way of background, I'm a wireless guy, but in 2002, I myself developed type 2 diabetes for all the reasons and genetics and family history. And so I joke that the two things that define my blood, one is good, which is wireless in my blood, and one is bad, which is too much sugar in my blood. But here we are at WellDoc. Jill actually started brilliantly with the statistics, and I'm going to put out a couple of more statistics for you. When you think about it today, the International Diabetes Foundation says there's 366 million people worldwide with this disease. We know that it's a leading cause of kidney failure, amputations, new diagnoses of blindness, and of course heart disease, both when you think about micro and macrovascular complications that diabetes causes, it's an ugly thing. When you think about the deaths, the World Health Organization predicts that they'll double between 2005 and 2030. Today, in the United States, we spend $218 billion on direct costs for diabetes. In fact, when you look at the indirect costs, 1 out of every 5 of our health dollars, so that's 2.1 trillion or 2.2 trillion, depending on who's counting, 1 out of every 5 of those dollars goes towards diabetes and its complication. It is a big, big problem. Our good friend Majid Ezati, who is a world-renowned epidemiologist, biostatistician at the Imperial College in London, says this is likely to be one of the defining features of global health in the coming decades. And there's simply the magnitude of the problem we're up against. And then there's the fact that unlike many other conditions, we really don't have good treatments for diabetes. One of the things that the panel is going to be discussing is why? And why is it this notion of what we're really trying to do is break down fundamental barriers of adoption and behavior to make these things adoptable by patients. So that's all diabetes. But then you flip the page and you say, what about obesity? Today, there's 1.46 billion overweight adults worldwide, and 502 million of them are considered to be obese. In the US, where more than 50% of the adult population is predicted to be obese by 2030, we have 1/5 of the obese population in the world today. When you think about the costs of obesity, staggering. They are estimated to account for, McKinsey did a wonderful study that concluded that between 0.7% and 2.8% of a country's total health expenditures are due to obesity. And Withrow and Alter at the World Health Organization say when you look at people who are healthy versus people who are obese, the costs are about 30 to 40% higher for those who are obese. So it's a big problem. So then you ask, how do we possibly solve this? How do we stem this, not only increasing incidence, but the ramifications? But how do we do it with the limited capacity that we have in our healthcare system today? And so the challenges, when you look at it at a macro perspective, the challenges are, there's awareness, right? How do you improve awareness? And of course, how do you manage socioeconomic ability? There's kind of two dimensions in a classic 2x2. And then at the micro perspective, it's all about behavior change. Amy's actually going to address that in great lengths and detail. How do you not just initially engage patients to manage them, but how do you sustain the engagement over time? There's, of course, these things have to fit. Whatever we do, your doctor says, go lose weight. We all know that. How do you actually fit these solutions within our workflow and what I call life flow? These things can't be orthogonal to what we do on a day-to-day basis. And of course, we have to focus on, it's too easy to focus on situational things, but nobody focuses on foundational things. How do we actually hit the root cause of what it is we need to solve? So we ask, how can technology help? And you know, there's this amazing thing called mobility. There are more mobile phones in the world than there are toothbrushes, I hear now. It's the latest statistic, which is kind of interesting. And there's this notion of seamless mobility. Instead of us going to our services, the services come to us. So is there a way to leverage and harness the value of technology that defines, if you would, solutions for different classes of users, for different applications, devices, services, business models, and of course there's that looming thing called regulatory. What do we do about that, and how do we operate within those confines? So to help us better understand this, we have a phenomenal panel today, and I'm going to introduce each one of them, and they're going to say a couple of things, and we're going to ask some questions. So to my immediate right, we have Amy Tenrich, and Amy is a journalist and an avid blogger and a patient advocate who started diabetesmind.com after her own diagnosis with type 1 diabetes back in 2003. So she and I share something that's not very good, but we share it nonetheless. Her site has become a leading online destination for people with diabetes. She's also community manager of diabeticconnect.com, the fastest growing and most successful social networking site for people with diabetes, with over 600,000 registered users. We then have, all the way down to my far right, Deepak Prakash. And Deepak is the global market segment manager at Avery, Dennison Medical Solutions, based out of Chicago. And he focuses on marketing and business development activities for the wearable sensor segment. Lots of innovation happening in that space. And prior to this, Deepak worked for Hollister and GE Healthcare in the areas of strategic marketing and product development. We then have, to Amy's right, Craig Lipset. And Craig is the head of clinical innovation within worldwide research and development at Pfizer. And Craig's team is defining Pfizer's vision for the future of clinical trials, enabling the initiatives and investments to create that future. Over 20 years of pharma and clinical research experience, academia. The pharmaceutical industry is going through so much change, and they're a key player and component in this battle against diabetes and obesity. And finally, last but not least, my good friend Sunny Vu. Sunny was chairman and founder of Agamatrix, the makers of the IBG Star. If you haven't seen it, this is really awesome thing that plugs into an iPhone. That's a little nugget. That's a blood glucose meter, which is a phenomenal innovation. The world's first hardware medical device designed to work with the iPhone, now marketed by, of course, Sanofi Aventis. He started as a raw two-person startup, raised a bunch of money. Sunny's actually been in that startup environment and raised a bunch of money in a lot of different pursuits and brings a lot of expertise from that. So with that, why don't I let you guys, if you would, your thoughts and perspectives on this, and then we'll follow through and we'll get some questions.
Thank you. Well, okay, I guess I should start by saying I'm somewhat of a poster child for someone who was diagnosed with a chronic illness as an adult, in my case, type 1 diabetes in 2003, and quickly became a very engaged, what we call an e-patient, so an empowered patient, just turned to the internet, was not happy with what I found there at the time, and just set out to kind of create the site that I felt I was looking for. Became very involved, obviously, in blogging, later on tweeting, Facebook, all of these social media applications that are now available, and the social networks for people with diabetes. As Anand mentioned, Diabetic Connect, which I helped launch in 2008, and now our latest statistics, I think we're up to 650,000 people with diabetes active on that site. So it's pretty amazing, and I can say from personal experience that the connections, the communication that's being enabled by this technology in these health social networks, the mentoring, the camaraderie, the education that people gain there, the ability for grassroots advocacy is changing people's lives. It's really already making a difference. And in the world that I live in, the fight we're fighting is trying to get the other powers that be, in particular the healthcare establishment, to recognize what we're doing with this technology and how it already is helping people, and helping them. We want them to help us to get the word out to the patients who are not plugged into that stuff. So that's my world, but we're here actually today to talk about diabetes and obesity and how the technology can help change outcomes. And I'd just like to remind you that what we're actually talking about here is behavior change. And how do you motivate people to live healthier in a society where you actually have to buck the norms in order not to become obese? I mean, we're being bombarded by commercial, marketing, aggressive marketing for delicious foods, cheap foods. Many people live in environments where there are 5 times as many fast food restaurants as there are grocery stores. So you have to think about the environment that people are functioning in. And no one has really cracked that nut on behavior change yet. So clearly, as we've discussed throughout the day, knowing that some gadget or web application is going to help you be healthier isn't necessarily enough of a motivator to get people to use it and to use it over time. So I think that what we need to do is dig a little deeper into human behavior. And some of the points that were brought up throughout the day, I mean, if we're going to create these apps and these programs for people, you need to make it easy, you need to make it fun, you need to make it engaging, you need to make it community-based. People do not do well in isolation with their treatments. You need to give people a sense of accomplishment over time. I feel like I see a lot of technologies that are cool and maybe do something neat with your blood glucose data, but there's no incentive to keep doing it. You just get burnout because there's no level to reach or change, some way to change it up so that people stay engaged. Make it affordable. Better yet, make it remunerative. So all these rewards programs, I think, are very successful. Obviously, there's things out there like Healthy Wage where people put up some of their own money and they're sort of betting on their own success. And those things have been very engaging for people. And then, of course, we need automated systems that can easily be shared between the doctor and the patient. You're surprised with Google Health that people weren't motivated to use this PHR. Well, it doesn't connect to the EMR. So if my doctor can't look at it, then why am I, it was a static platform and it wasn't connected to the people who matter in your care. So pretty clear. So on top of that, I think the traditional approach of both the pharma industry and the technology industry, as we all know, has been to sort of push out new applications, devices, and services kind of based on what they consider use case scenarios on their own R&D capabilities and on sort of assumptions about what people need or what they want to do. And I have been a big proponent of changing that game, really making the starting point be a real patient-centered perspective by beginning with understanding the real health challenges of people with chronic illnesses and also people who are just trying to lose weight and live healthier, and look at the context, look at the environment they're living in, what people around them are doing, what's going on in their community. And I've actually run an innovation competition for the last 3 years called the Diabetes Mind Design Challenge, which was a patient-led initiative to get exactly at this point. I worked with IDEO Design and the California Healthcare Foundation to run this web-based crowdsourcing competition. It's open to anyone, And the idea was for people, patients and caregivers and people who are involved in this illness to actually come with their own ideas about what are the best tools to improve life with diabetes. And we had hundreds of submissions from universities, entrepreneurs, patients, caregivers, designers all over the country. And last year, we also hosted a summit at Stanford University, which we'll be doing again this year, to bring together diabetes patient advocates, many of whom are living with type 1 like myself and have to deal with these devices very intensely throughout the day, every day. Bring those people together with pharmaceutical executives, Health 2.0 innovators, entrepreneurs, designers, investors, mobile health experts, gaming experts, and everything to sort of further the agenda of putting patient needs at the center. Because patient-centeredness is very much a buzzword, but I know from living with this illness that it is very much a buzzword, and it isn't reality yet. So we talked a lot today about not just technology for technology's sake. I'm 100% behind that, and I think that it behooves us to take a really hard look at the environment and the behaviors that are behind this diabetes and obesity epidemic, and to design to those real needs.
Excellent. I'm going to pick up on a couple of the things that you said when we come back to questions.
Very good. I'm Craig Lipset. I work in clinical research at Pfizer. And so you may ask, well, why would Pfizer be here at CES? So I guess the first question is, what does Pfizer do? And a lot of folks probably know the name Pfizer for some of the products like Centrum or Advil or some of the other pharmaceutical products that we have, some of which have names that I hope you never hear because they're for various forms of cancer or other life-threatening diseases. But at Pfizer, we take a great interest in the space that we call connected health. The idea of the range of tools that consumers and patients are increasingly using to help to manage their health and wellness. And we have that interest for a few reasons. It complements the range of work that we do at Pfizer every day. So I work in clinical research, and there are huge opportunities for me to leverage and repurpose novel sensors in new ways to help answer some of my research questions as I'm better understanding the efficacy and safety of our medicines. These tools, though, also complement, as we develop different disease management strategies, they complement a lot of our commercialized medicines as well. But in many ways, these tools, these sensors, will all become quickly commoditized. And it's the data to us that matters most. It's the data that's a constant. Recently, our CEO, Ian Reed, was speaking at the Cleveland Clinic, and he was talking a bit about what Pfizer does. And he actually used the descriptor that Pfizer is a data company. And I think that's an interesting descriptor because in many ways, that is what we do for a living. I generate data about our product's efficacy and safety through clinical trials. We communicate that data to regulators, to healthcare providers, to patients. And then we continue to track and understand data about how our medicines are working in the real world, their ongoing safety to share with regulators, providers, and others. So we manufacture medicines, but we're really in the business of understanding the data around those medicines. And in a world where healthcare is increasingly connected, it's increasingly participatory, I think that data is really rising to the surface in terms of how we share and continue to track and share data. And I think that's where this digital health story becomes most interesting to us, because these devices, these tools enable sophisticated ways of capturing data, sophisticated ways of aggregating and sharing that data, and helping us all turn that data into actionable information.
Hi, I'm Sunny Vu. I was formerly with Argomatrix, as Anand was mentioning earlier. We made blood glucose meters and strips, and then the glucose meter that works with the iPhone. That was a lot of fun, and my passion there, building the company was great with my partner Sridhar. I think he's in the audience here. We had a great time. Left the business about 6 months ago to start a new company. Actually, I went to go on vacation for the first time in a while, and came back to start a new company with John Scully. I think he's speaking tomorrow. And we've been having a blast since then. We named it Misfit Wearables because we were sitting in Cupertino talking about it, and we incorporated the business, and then the announcement that Steve had died came. So we were incorporated on the day that Steve Jobs died. Not by design, obviously, but so we said, oh, let's name it in honor of him. So if anyone knows the commercial. And so we're focused on wearable sensing technologies. Been working with sensor technologies for a long time, picking up on what was just said on data. Love data. It's a great tool, a great enabler for all sorts of services and products and things that you can make that'll revolutionize the face of healthcare. And every time I hear the word sensors, though, I think, man, that's like saying vehicles. You've got space shuttles, and you've got bicycles, and there's a wide range of these things. And if you're doing electrochemical sensors, they're still pretty hard to make and manufacture. 3-axis accelerometers, which is in just about every consumer health device these days, which is consumer device for that matter. Those are completely commoditized, and you can buy them off the shelf. You can go to Radio Shack probably and buy them and put them into things. And so it's not an elusive notion. They're very clear. It's very clear what a sensor is. It's just that the range of them is quite broad, and there's still basic research to be done to get better sensors to sense things that we haven't been able to sense before, and all the way to all sorts of innovations that are still open, still available to invent, to use data, to embed sensors into things that we have. In my previous life, and even in that, and especially now, we had this notion of the turnaround test, and that was, if you are 20 minutes away from work, that's, your commute. I mean, maybe in California that's a really nice commute, but in the New Hampshire area, that's a short commute. That's a long commute. And if you're 20 minutes away from work, and you've left your house, you're 10 minutes in. What is X? What is a thing that you would come back for if you forgot it? And we said, okay, rather than being a nice to have or I should probably have it type of device, how about a device that you would turn around for? So, would you turn around for your blood glucose meter? Maybe not. Some folks, your pedometer, yeah, maybe. Your iPhone, definitely. Wallet, keys. Okay, so I thought, so we're thinking, I'm thinking here with Misfit, we'd really like to invent things that are that you turn around for, and I think that those are. I would posit that those are the table stakes for new devices to be really useful. Is if you can be in that category of pass the turnaround test, you got it, or at least come close. And so I've always been passionate about delivering user experiences that will be truly delightful for people. We don't have to call it healthcare. We don't have to call it medicine. I think there was a famous person who said that if you added healthcare or medicine to something, it's like adding Brussels sprouts. You just don't want it. Or to ensure that no one will order something from your menu, just put in the healthy section of the menu, right? So we don't have to do that. So I think ease of use and user delight. User delight. I think that's something that's missing from a lot of our discussions, and I'd love to hear more of that in what we talk about. And then, of course, just extreme utility in terms of good use of data, good patient-centric design, that type of thing, all good stuff. So that's what I've been passionate about. I think we'll talk a little bit more about that later.
Cool. Thanks, Sonny. I'm Deepak Prakash with Avery, Dennison Medical Solutions. We're kind of new to the wearable sensor space, but with our partners, Proteus Biomedical and Body Media, we're trying to bring new technologies into the marketplace. And one of the things with diabetes is we're very good at taking action once you know you have diabetes. But kind of the awareness at the pre-diabetes level is pretty low. And part of it is it's this, if it ain't broke, don't fix it mentality. Hey, I don't have any symptoms, so I have no problems. But the risk factors are just the same. So part of someday, down the road, very shortly here, you'll be wearing technologies like this, our sensor technologies that give you insight into your body and give you the physiological information, give you the context, tell you more about your body so you can take steps, understand the risk factors. So that way, granted, if you have, risk factors pre-diabetes, okay, only 10 or 12%, I forget the exact percentage, go on to have diabetes, but the risk factor is just the same for other disease states like kidney failure, et cetera. So it's important. That's where we feel we can make a difference by bringing, you mentioned, hopefully the sensors won't get that commoditized, but sensors with the data and the algorithms and the intelligence into your body and incorporating this as part of the healthcare continuum. I think the physicians someday need to tell you, just like they say, go get a flu shot. It's so common today, top of your mind. The same thing, diabetes is such a big problem now. I think that kind of mind share is required, where technologies like this that are right at your fingertips, that tell you what it is that you're doing or not doing, and give you guidance on what steps you need to take, that's going to make the difference. Diabetes, it's the train's left the station. It's a runaway train right now. And so you got to address this from a completely different perspective. And starting with, behavior is a big part of it, and giving tools and data, technologies like what we're developing, to help them make intelligent decisions. Hopefully someday we'll stem this epidemic.
So I'm gonna, the fun of these discussions is you script them to the T, and then you throw the script out because everybody said something different than, and so I'm gonna actually go out of order. I'm gonna go out of sequence here, and I'm gonna pick up on this notion of data. All of you have talked about data. And there's a part of me, if I were to play devil's advocate, that says, the analogy I would use is when you're driving on the freeway and you turn on the traffic report. And it says, this bridge is closed and there's an accident here and, blah, blah, blah. And what do you want? You just want to know how to get home. All that data is very interesting, but just tell me how to get. In fact, how you get home on a Tuesday may be different than how you get home on a Thursday because there's traffic patterns. It's no different for a patient. So now I know my glucose. If I got a meter, in fact, you know what? I have all these knowledge websites about all these things I should do. And I have all the labels on foods that tell me what's good, what's healthy, portion, all that stuff. But it's all data. And so maybe the first question to Craig is, yes, we can collect data because we can. We can generate more data because we can. But what do we need to do with that data? What can technology do to convert that into action?
So I think the first step in that process is to collect the right data that can demonstrate what this thing is. If it's a patch, if it's some other mobile app, whatever that tool is, show me the data up front that it's actually correlated with something meaningful, that it's correlated with a clinically relevant outcome. And that takes time and money, by the way, right? That takes the time to do a trial to show that your intervention affects A1C levels, or that your intervention affects percent body weight after X number of months with that intervention. Because short of that, it's just a good idea. And that's why, and that is why that doctor tells that patient, go get a flu shot, is because somebody generated the data behind it. And so I believe that as we collectively, and through some very clever institutions that have been developed over the last few years, help to collect that data that correlates with meaningfully relevant outcomes, that will be the first step in that process. I think from that point, we now have this ecosystem where, you're right, we're constantly collecting data. And so how do we turn that into meaningfully relevant information? I had myself genotyped recently through through all of the consumer genetic testing companies. So I've actually been genotyped like 4 times now. And some of the big actions that I got, some of the big takeaways were exercise more, watch what you eat, and don't smoke. Has anyone ever heard that before? I know this is very sophisticated. I don't want to talk over your heads because I'm talking about genetics. Has anyone ever heard that in terms of information or action before? Yeah, you probably have, right? We've heard this advice before. And I think we know the consequences, right? It's hard to talk about showing and representing data in a way that will modify behavior when the implications. Okay, so what are the implications if I don't take my diabetes medicine correctly? I may die. So I would suggest that preventing death is a pretty good motivator, right? And that all the badges and gamification in the world shouldn't, in theory, be any better a motivator for me than preventing my death.
So challenge that, and I'm going to go to Amy here.
Yeah.
Amy is the behavior advocate, right? You're the patient advocate.
I'm your reality check.
You're the reality check. More data. You know, the reality
Data's
is,
not gonna help
as much as, so devil's advocating, as much as my doctor tells you, you got to do this because you're going to live longer. Sometimes that just doesn't work. People don't comprehend that. They don't act on it. So what do we need to do? What do we need to do to break down those barriers, and how can technology help to do that?
Yeah, I mean, the whole pre-diabetes thing. Someone had to give the mom example. I'm going to give the mom example, okay? Here I am, type 1 diabetes, near death a few years ago, blah, blah, blah. I wear all these sensors. I wear an insulin pump. I've gone through all this stuff. My mom is told by her doctor that she has pre-diabetes. What did she do about it? That. The big zero. Because it's like, I don't have it. I don't have anything yet. I feel fine, Just not, the connection's not there. So I also think that, no amount of data is going to change that. Sometimes people have to have a life-altering experience in order to actually change their behavior. But just going back for a minute to how data can be more useful. A couple of years ago at the American Diabetes Association, which I always cover, all the vendors were on this kick about data visualization. So as you know, everybody thinks the holy grail for diabetics is being able to have these reams of records of your glucose data. Most people, honestly, most diabetes patients out there with type 2, or very many of them, don't even know what the single number on their unit means. So what are they going to do with reams of data, of single data points? It's useless. So these vendors got the idea that people need a more sophisticated way to visualize their data. So they were investing.
Now you can graph and see how bad
Exactly.
you're doing, right?
Well, they spent tons of money making these extremely fancy ways for you to run different reports, like we're all some kind of engineers, as if we didn't have enough to deal with, right? And I actually went around and told every single vendor, this is useless. People need to know what to do with the data. Most people, again, don't get a good basic information about, I'm always shocked at people who have family members with diabetes who don't understand it, but if you ask the patients themselves, they really don't understand it. And a lot of people aren't given the basic information of what that number means, when to test, what to do with that data. So this last year, they've sort of finally changed around to starting to look for more, I forget the term they're using for it, but basically, trend analyzation and actually smart apps that are starting to not just present the data in all these fancy ways or push data at you, but actually alert the patient specifically to trends, to be able to say, to actually have the device itself notify you, look, you've been going high every afternoon, or you're running too low at night, or giving you actually predictive alerts and giving you some kind of interpretation of that data, and also suggestions about what to do about it.
So I want to come back to this notion of personalization of that data. And Sunny, I'm going to come back to you in a second, but hold the thought. Deepak, if I think about our health system today, one of the things that I still can't understand is that nobody has any problem paying me $40,000 to cut off my foot after
Right.
I've had all the complications. But the health system isn't geared for preventive care today. Nobody's going to pay you $10 a year to go and actually get a foot exam. The system just doesn't do that. So this concept of data and this concept of technology as it relates to, I was reading this great book by our good friend Fran Kaufman, who was a former chairman of the American Diabetes Association. She's a professor of pediatric and endocrinology at UCLA. She wrote this book called Diabesity. That's great. There it is, diabetes and obesity. It's diabesity. Can we take this data and can we use it more effectively, perhaps earlier in the care continuum? Are there things we should be doing earlier and not just focusing on this acute? So is there a role for technology to play earlier?
Absolutely. And one of the things I wanted to add on to what Amy said, kind of behavior is driven by if you give information to people. I think you've seen with a lot of these mobile apps and et cetera, information is coming to the patient. So the more information and the more tools you give them, hopefully that'll be enough of an incentive, other than they're dying, enough of an incentive for them to make a change. True, I agree. The payer system is completely misaligned. It's on one side, so they need to be brought in much earlier. I think we can draw some lessons from other realms here. For example, of all these programs, tobacco cessation is considered, I guess, somewhat successful. But see, they're able to influence your employers to give you incentives, discounts on your premium if you participate in smoking programs, et cetera. Diabetes and pre-diabetes and taking these things seriously probably needs to be put at the same level. I'm sure a $25 discount on your healthcare premium probably won't cut it, but something bigger to enforce the seriousness of the issue. I agree. A payer, all this clinical data, user, patient, and then of course there's the payer here, kind of all alone, and they need to be brought in, and their incentives aligned properly as well. Definitely agree.
You were going to,
Yeah.
Please.
I wanted to mention, I know Fran quite well, and her husband actually launched a company that's one of the best examples, I think, of using technology to actually help people with obesity, combating, being overweight and also dealing with diabetes, and that's something called DPS Health. And what it is, it's a technology-enabled behavior change intervention for people with type 2 diabetes across the U.S. They've especially tested it in rural areas. And really why it's so powerful is because it brings together both a technology element, so a sensor that people wear. They use this accelerator that these heavy patients wear just to start to get a sense of their own activity levels.
Sure.
It's really just sort of like the equivalent of keeping a food log, but you don't have to write anything down. You wear this thing and it tells you, it gives you a sense of, my gosh, I'm not really, if I took the stairs, that gives me 25% more action. But it's combined with a coaching program that is connected to educators and doctors. So it's like this full program where they're using online educational modules, they're interacting with providers and coaches, and they're also wearing an accelerator sensor where the data is then shared with, there's someone on the other end, a healthcare professional who has the incentive and the reimbursement to actually be spending time with that data and then teaching the patient. So that's, to me, one of the best examples of a program. But the problem is that fight to get the reimbursement for, to get a program like this implemented further across the country, because it is expensive, and it's a preventative measure as opposed to just waiting to see how many of these patients get really, really sick later on.
Yep. So hold the thought on reimbursement, because we're going to come to that too. But now I want to go to Sunny, and you're like the quintessential advocate of simplicity, right? How do you, if I think about what you guys did with IBG Star, the iPhone, right, wrong, or indifferent, represented simplicity in people's lives. It represented a means of converging things that you would otherwise do, perhaps with different devices, but it brought them temporally together so you could actually interact with this at one point in time. So, question for you, Sunny, is there an inevitability of this mobile platform as being the convergence of these types of solutions that can help us manage not just diabetes and obesity, but other chronic conditions? And if that's the case, what are the things we need to do in the case of data presentation or in the case of sensor integration? What are the things we need to do to keep this thing simple and engaging?
Well, maybe I can answer with an analogy, and it might be an extreme one, but if we were to teleport ourselves back maybe 3,000 years and someone said, do you believe paper will be the convergence of where healthcare will go, where people write down information and give it to people? Yes, this will be like paper. Okay, all right, well, so let's move on, because you've got your laptop, you've got your tablet, you've got your phones, and what else are you going to want? Another iPhone? Okay, so do you want more paper? No, okay, we've got paper. Let's work with it. So so mobile will be, these types of display devices will usher in a new era in healthcare management. Blah blah blah. Okay, so we all believe that. Where will it head? And I think it's two ways. Where will computing head? To the cloud. Lots of startups and big companies doing that now. And the other is to your body, to the very things that you wear, like a T-shirt. And so, but if I were to go back even earlier, we went with Deepak. We went earlier, and then I'm saying let's go even further back up the chain. And I want to address something that I keep hearing, and that is, while we're swimming in data, we don't know what to do with it. Data is useless. It's really information that we want. Actually, we want insights, not just information. Good. Okay, we all agree on that too. So I think these are all good table stake kind of axioms to go by. But what I would say is even earlier on, I think it's that I don't actually think we have enough data. I actually think the first mile problem is not solved. It is actually surprisingly more solved in diabetes, I think, than other disease states. Like, we have devices that you can actually implant on your body subcutaneously that will continuously measure stuff. That's amazing. Like we don't have that in other, you don't have implantable pedometers. And what's the key issue with pedometers? You don't wear them. They won't pass the turnaround test. If you forgot them at work and you're at work or halfway to work, you're not going to turn around for it. So,
but we would kill for a non-invasive monitor. It's not by choice.
Yeah. So
It's the
we're
only way
not
that
there
works,
with
right?
diabetes yet. Okay. But it would be great. You're right. It's not by choice because it's not there yet. So what I'm saying is there's another set of problems: data analysis and insight generation, and decision support, like what WellDoc does, which is freaking awesome. That's great. A lot of great startups and innovation to be made there, and I think this is just this blue ocean of, stuff that can just ambiently measure things and generate data, so that you guys can analyze it and generate insights. And that's where I think one cluster of innovation will happen, and that's what I'm excited about. Mainly because if people don't have to remember. That would be really great. And so just the one thing that I thought of was, what are things that we're trying to simplify? So what I'm talking about is data entry. Entering your glucose data or entering your activity information or what you ate, and that sucks. That's horrible. Data acquisition is just like socially unacceptable. Like, hang on a second, let me enter how many carbs I got here before I eat this steak. Okay, that's no good. Data interpretation and transformation of data into useful info, that's what you guys do, as well as decision support. That's like, I think you've basically proven that there's an industry to be had there, which is pretty amazing. Data transfer, you hear a lot of the usual rants at the EMR conferences about data transfer. Well, those are not technological issues, they're policy issues. And behavior modification, that's the last one, where you're doing motivation and mental hacks, basically, to help people to change what they do. Great things there. And if I were to just make a final comment on that last piece on behavior modification, I've just been brainstorming, like trying to understand, well, what do we have to do to get to really make behavior modification work? And well, I thought of primal instincts, 5, maybe 6, and I'll be a little provocative because it's just brainstorming, okay? So we're just sharing here. So I thought, okay, bribes, okay, money, that could work. So you hear about rewards,
Money
right?
works, yeah.
Okay. Games, you hear about the gamification thing. My personal view on gamification is I think we need to healthify games, not gamify health. Like, let's start with Fruit Ninja, my favorite game. Let's go to Shani O'Dale, who makes this incredibly ingenious game, who has, a zillion players. And then if you just have the Fruit Sensei say something insightful about diabetes, that, that's instantly gets to the, 8 million Fruit Ninja, diabetic Fruit Ninja players out there instantly. How long will it take your health game to get 8 million players? Forever. Third, so rewards, games, social pressure. So like, fear, shame, guilt, desire to boast. These are, they all sound negative, but I'm sure there are positive social pressures that you can leverage too. But yeah, social pressure in some ways. There are a bunch of startups there. Sex, I don't know how you can do that. I saw a posting recently that says diabetes needs porn. I would not advocate that, but I've heard that before.
Maybe next week at a conference.
Because I heard
what happens in Vegas stays.
I heard the stat that the third biggest use of the internet was what was it? Searching for healthcare information. I didn't know it was searching for healthcare. And the fifth one, I would say, and I wouldn't know, but so the fifth I would say. Again, another one, again, in the spirit of brainstorming, gambling. Gambling mechanics is something that I haven't seen much, you're starting to see it in some games where you can win little things, and there's a little slot machine, like in Jetpack Joyride, great game. You can earn these little tokens to play a little slot machine. And then last, and definitely not least, I guess the sixth one, inspiration. If there's a way to truly inspire people to generate intrinsic motivation for behavior modification, I would be all over that.
So let me ask a structural question, because all of this sounds awesome. I mean, you're unleashing the full capability and potential of technology and connections and social networks, and it's for the mathematician in the crowd, it's the n times n minus 1 divided by 2, right? It's I got all these things going around now, right? It grows quadratically. It's amazing. Now you're sitting in the shoes of Pfizer, and you're in the pharma industry, and in many ways, you guys are creating part of the solution in terms of drugs, therapies, et cetera. But this is stretching your imagination in terms of what you guys are comfortable with doing as an industry with data. Now you're talking about, I want to share it with so-and-so on Facebook, and I want to, if that's what motivates me to manage my obesity or meals, have at it. How do you guys address that within the pharma industry?
So let's take sort of the entry point of behavior modification in the pharmaceutical industry, and it's medication compliance, right? So many of us, at least in my industry, we know the numbers well, that within 6 months of taking an anti-cholesterol medicine like Lipitor, within 6 months, 50% of the patients are no longer compliant. And if you only took Lipitor for 6 months, you will clinically not receive any of the benefits that you could or should in taking the medicine. So multiply that times our entire portfolio, times our entire industry, the cost of the healthcare system, and so on. So a lot of smart people for years have been trying to explore behavior modification applied to medication compliance. And still, even with all of these very sophisticated, very academic, very scalable interventions, there has hardly been a significant solution introduced. Something that really in a meaningful, long-term way for somebody managing a chronic disease is now truly motivated to make change. So enter the world of CES, enter the world of exciting technology. And what do we get? We tend to get reminders. We tend to get brought, look, I've got a new way for you to be reminded every morning at 9 a.m. that your phone will beep and it will say, take your Lipitor. Well, I already had a Jewish grandmother. I had 2 of them. I don't need an electronic nudge. I don't need to be reminded to do something that maybe I didn't want to be reminded to do. So to me, getting beyond that low-hanging area of reminding and getting into some of the more sophisticated and exciting opportunities that technology brings to us today, that social aspect, some of those other mechanics that we can bring in, because reminders aren't new, right? We've sent letters, we've done ways to remind patients before. Patients don't just forget. The reasons for noncompliance are multifactorial. Forgetting is just one of many factors. So taking advantage of technology to try and hit on those multiple factors, that some of which you were just walking through, some of those exciting opportunities that technology and the connectivity helps to bring, that to me is some of the exciting opportunity here.
So you hit the nail on the head. So last question, and then we'll open it up for questions from the audience, is what we're really talking about. We're sitting at this nexus now, right? We're sitting at the nexus of CES, cool, whiz-bang, new stuff, sensors, fun stuff. I'm not going to go down that path that you're going, saying maybe it's sex. I don't know. Who knows? We're in Vegas, right? I mean, there's all these things coming together. Does it require then, Deepak, does it require the health system at the political level, at the value chain level, between different companies that play different roles along the health delivery, if you would? Does it require a new form of collaboration? Are there better forms or different forms of collaboration that are required to take this monkey forward?
Absolutely. Some kind of creative public-private partnership is required. Like Novo Nordisk is pioneering a pilot in diabetes, and it's turned out to be successful. I don't know how scalable it is, but that's a start. A lot of creative ways, government policies, for example, in some of the African and Asian countries, even buildings, how they design buildings, they're incorporating where you walk some distance to take stairs, et cetera. So, something very creative. They're looking at ways to inject these kinds of thinking into that. So the magnitude of the problem is so big, you can't just do one thing here. You've got to attack this from every possible angle, socio-political angle, every possible angle possible. Otherwise, this is just going to keep climbing and climbing, and it's just going to go out of control. It already is out of control, but even more out of control.
The point about stairs is an amazing one.
Yeah.
How many people in their office buildings today, where are the stairwells? They're all hidden in the corners. They're poorly lit. You don't want to use them in, if you're alone and blah, blah, blah. And you look at some of these new buildings, and they're out in the open, and they encourage you to use it. And so I think it is that kind of broader, we got to. So are there questions as we bring this panel to a close? Are there questions from the audience that we want to take? Did we answer them all? We couldn't have possibly answered them all.
Perfect panel.
We couldn't have answered them all. Nobody, sir?
Hi, I'm Kerry Enright. Recently I saw a presentation of blue zones. And blue zones, there are 5 blue zones in the world. 4 of those are some of the most remotest places in the world from healthcare and digital health. And people live very long, very healthy lives to the very end. And some of the things, if you look at what makes people really, really healthy, they are social types of things. They are community things. The number one thing that makes people live long is religion, and number 2 is community. And here we're talking about devices and applications. Are we missing something? Do we have to take what we have, this whole array we're doing, and move it up a notch to grasp a whole new set of motivations that are beyond our discussion?
Why don't you?
I'm so glad you said that. That was definitely my point as well. I think this is a community level problem. We did a post recently on my site about the growing epidemic of children and young people with type 2 diabetes, and we queried about 6 of the country's top experts, including Frank Hoffman, and not one of them said, we need a new app, we need some new technology, we need a data sensor. Nothing. You know what they all said? The one thing they all had in common was it has to be a family initiative. Mm-hmm. So it can't be the parents telling the kid, you have this health problem, you have to do blah, blah, blah. You have to eat like this. People model behavior. It's social environment. It's also the physical environment in terms of what foods are just in the house.
Sure.
And that was the number one thing that they said about childhood obesity is having it be a family issue and being aware of the community and that what's being offered in the school and elsewhere, but mainly modeling behavior and sharing foods, and also whether the parents are physically active, they can't simply turn and say, you need to do this. They have to do it too.
And building off this comment of community, there's certainly community with the end users of this. So let's say it's a child with diabetes or an obese child, and their parents who have to manage what they eat. At the same time, it's a collaborative effort. It's interesting to see the likes of companies like Nestle and Pepsi, who are looking to the future saying, we want to be healthy food companies. And we want to participate with the schools and the school programs to make sure that snacks are healthy and things like that. And I think it's going to involve, it's to your point, you got to ratchet it up to a different level of ecosystem collaboration.
Bob Goldberg, I wanted to follow up on something Sonny said about the primal factors motivating behavior. The most effective public health initiative in the last decade was launched by Andrew Wakefield, who claimed that vaccines cause autism. That one study, which of course was false, was spread throughout the media, throughout social media sites, and has caused epidemics of whooping cough and measles in some of the richest parts of the United States. So I guess the question I have is, and the other thing I should point out is that companies like Pfizer, if they want to say something about their product, they're regulated. Someone like Andrew Wakefield can say anything he wants about, diabetes or vaccines. How can we use the tools that you're developing? Because on one hand, we're all focusing on, we're going to change outcome. But for most people who are healthy and may get sick, they're afraid of what they don't know. And we have to how do you figure out a way to help tamp out a lot of the fear that goes viral, which really does contribute to lack of compliance and real public health problems?
So it sounds like you need to publish a paper that obesity causes autism.
Well,
refuted years later.
Well, we had the same mother, because she used to say, if you run around and if you go in the water on a full stomach, you'll get cramps and die. So,
But one of the things that did take Andrew Wakefield down was social pressure. Right. Once the blogosphere got word of the study, they just went into such level of detail that your traditional media is not incentivized to go into that level of detail. So I think this community pressure works. That's what completely debunked his study. So I think that level of thinking.
So it's self-correcting in some
exactly
in some way, but it takes time for that self-correction.
I know.
Yeah.
He did a lot of damage in those 10 years.
you have to be ahead of the curve.
Yeah.
So I'm sorry we can't take your question. We are trying to run on time, and this is a really complex issue. Fantastic. Everyone.
Thank you.